Good morning, everyone, and a very warm welcome to this Irwin Mitchell webinar on the psychological aspects of pain. Thank you to everyone today for taking time of your day and joining us for this event. We hope that with our virtual events, that even in these strange times, we can continue to bring our clients, communities and colleagues together. My name is Adele Jepson. I'm a solicitor based in the serious injury team of Irwin Mitchell in Newcastle upon Tyne. I'll be joined by the brilliant Professor John Morgan, who'll be taking you through his presentation on this very interesting topic. This event was originally supposed to take place in person in our offices in Newcastle back in January 2020, but was delayed until April due to Professor Morgan's court commitments. Unfortunately, of course, the world that we know now has changed in light of COVID, and here we are delivering this event to you virtually. The positive of that is that we're now able to host this for so many people. When it was supposed to be face-to-face, we were at full capacity and had a waiting list for attendees. We're now able to deliver this event to around 400 people today who've signed up to watch this live, and there'll be lots of others who'll be watching the recording who cannot join us right now. Thank you to those who have already submitted questions. As there's quite a lot of people joining us, there is a lot of questions. Professor Morgan will be addressing as many of these as he can as part of his presentation, but if you do have any further questions, please submit these using the Q&A function. As we do have a lot to get through, we are likely to probably run out of time to deal with all the questions, both those that are pre-submitted and the live ones. So can I please ask that you leave your full name and email with your question, and that way we can look to respond to you directly after the event. As I mentioned earlier, the event is also being recorded, and a link to this will be sent out afterwards. Towards the end of the session, we'll be also posting a feedback link in the Q&A box, and would really appreciate you taking the time to complete this and provide your feedback on the event today. So without further ado, I'll hand over to Professor Morgan to take us through today's session.
Thank you very much, Adele, and I'm very honoured to be here today. I can see there's a very illustrious list of attendees with various levels of experience with pain. I'm trying to talk sort of in the middle, so there are some people who may find that what I'm saying fairly basic and other people may find it slightly baffling, but that's sort of inevitable, I think. This is a talk about psychiatric aspects of chronic pain, and I'm a consultant psychiatrist who has had input to pain management services in the past. A lot of the psychological therapies for pain are delivered by clinical psychologists, and psychiatrists often get involved with the perhaps more out of the ordinary types of cases. I'm going to give today's talk a bit of a legal angle, particularly in view of developments in terms of the classification of pain. And I'm mindful of DSM-IV, the American Psychiatric Association's classification, and a particular category called somatic symptom disorder. So a lot of my talk will be referencing this condition, somatic symptom disorder, which clinically has advanced the way that we approach pain, because it avoids what you could call is a false mind-body dualism, that pain is either physical or it's psychological. And the classification based on somatic symptom disorder avoids that, it bysteps it. On the other hand, the problem with somatic symptom disorder is that it's led to a rapid expansion of such diagnoses, and particularly in America, somatic symptom disorder has become one of the most litigated diagnoses, and one in which most claimants are actually losing. So on the one hand, we have new developments in the way that pain gets diagnosed and classified. On the other hand, there are problems that can emerge from that. And I'll say a little bit more about that shortly. Next slide, please. So I'm going to talk a bit about how we classify and define pain from a psychiatric point of view. I'm going to talk about the prevalence of psychiatric illness in chronic pain. I'll touch upon the mechanisms of pain from a psychiatric point of view, but I'm going to cut short that bit of my talk in the interests of answering more questions. And finally, I'll explain how a psychiatrist might go about the assessment and treatment of people with chronic pain who are presenting with psychiatric issues. Next slide, please. And then could you jump that slide and straight on to the next one? Thank you. So I think the problem that we all have with pain is that it's essentially a subjective experience. So pain, it presents a philosophical challenge in how do we define it, and therefore in a legal setting, how do we prove it? Pain involves some cognitive awareness. It involves cognitive interpretations. It involves certain behavioural dispositions, and it's influenced by cultural and educational factors. I remember as a schoolboy, suddenly at school, when playing football, lots of kids would sort of fall to the ground and roll over, clutching their legs as if they were badly damaged in a fairly minor tackle. And it baffled me what was going on until I realized that they were imitating footballers. And so you can see how pain behaviors get shaped by what people observe around them. Now, Virginia Woolf gave, I think, what is this marvellous quote: the merest schoolgirl, when she falls in love, has Shakespeare or Keats to speak her mind for her. But let a sufferer try to describe a pain in his head to a doctor, and the language at once runs dry. Here we have the conundrum in a legal setting of how we characterise pain, and how perhaps an eloquent barrister who's used to standing up and talking with great fluency will find it easier to put words to their pain than some of the clients that we might see who perhaps don't have the same level of ability to communicate. And this causes us to make judgments about clients if they're not communicating their pain in a very effective way. We talk about abnormal illness behaviours. We talk about attention seeking. But of course, sometimes the best attention seekers are consultants or barristers who have the social skills to draw attention to their distress, whereas the clients that we're seeing don't have those abilities. And therefore, the inability to put words to pain can cause misjudgments of the patients that we're evaluating. Next slide, please. So as a psychiatrist, I approach pain really with these four domains in mind. There's a cognitive element, automatic thoughts like, oh, I'll never manage to cope with this. Then there's the mood element, the affective element, and the profound melancholia with which patients present. There are the behavioural elements of pain and pain avoidance behaviours in particular. I think there are some physiotherapists in the audience, and I think there's a key role for physiotherapy in trying to overcome the psychological pain avoidance that becomes a deeply ingrained pattern. Then there's the sensory element of pain, the basic element of pain. But in the middle of this talk, I'll say a little bit more about how pain sensation becomes affected by people's memories, people's experiences, and essentially, if I stand on your toe, a message goes from your toe to your brain saying, ouch. But equally, your brain is sending messages downwards, which will affect the threshold for that ouch. So pain isn't just that sensation, it's based on learning and memory. Chronic pain also differs from acute pain in that if I stand on your toe the once, you're going to say ouch, your blood pressure goes up, you try to run away, or you try to hit me. And those are behavioural adaptations. Whereas with chronic pain, that effect wears off, and there are fewer observable signs. Patients can seem quite apathetic and withdrawn. They can seem inactive, or they can have rather blank facial expressions. So there can be an absence of reaction in people with chronic pain at a behavioural level. The other aspect of chronic pain is its remarkable response to placebo. So particularly with severe pain, placebo responses can be very strong. And responding to placebo isn't indicative of malingering, though I've been in cases where the defendant has tried to present placebo response as a sign of malingering. And we all see cases where patients go from one pain intervention to another, and they seem to improve for the first 4 to 6 weeks, and then that improvement starts to wear off. And again, this can be a sign of this placebo response, which particularly correlates with more severe pain, or with pain that's associated with anxiety, and also whether placebo prompt itself is potent. So in the old-fashioned days, doctors would produce sort of foul-smelling liquids with sort of green liquid, and that would convey to the patient a sense that they were about to be cured because they were going to suffer. And so it is with pain treatments, that the more intense the treatment, the more likely the placebo response. Next slide, please. So the classification of pain until recently has not been very adequate. And from a psychiatric point of view, we've found in pain, in some pain clinics, that the suggestion of a psychological cause of the pain becomes almost a rubbish bin diagnosis of patients who've been through the mill of various physical investigations, and then nothing has been found. So the diagnosis of a psychological component becomes a diagnosis of exclusion rather than a diagnosis of inclusion. One of the attractions of somatic symptom disorder is that it does require some degree of positive psychological formulation of the pain so that we understand the causes of it. And I think that's a step in the right direction. Next slide, please. So DSM-IV is now replaced with DSM-V, but most of my professional life I've been governed by DSM-IV, in which there have been a wide variety of different diagnoses, all of which have included pain elements. So as a psychiatrist, pain crops up in cases of somatization disorder. Sometimes there's a very pure pain syndrome exemplified by persistent somatoform pain disorder. And then this rather sort of fluffy category of psychological and behavioural factors associated with disorders elsewhere, which is quite a mouthful. And that would include, for example, migraine, in which stress is a component. There's elaboration of physical symptoms for psychological reasons, also known as fictitious disorder. Then there's malingering, which is relatively rare in my clinical practice and a far more common suggestion when it comes to the legal arena. However, clinical depression itself involves pain. 60% of people or more who are presenting to their doctors with depression will have pain as a prominent symptom. And there are some sort of cultural groups where they simply won't go to their GP saying, I'm depressed. They're far more likely to go to their GP saying, I've got tummy pain or I've got chest pain. So sometimes pain is a core symptom of clinical depression. And then there are psychotic disorders in which schizophrenia is one, where there may be delusions or somatic hallucinations of pain. And the beliefs around pain are quite delusional and can be very difficult to treat, very fixed, and sometimes associated with a degree of dangerousness as well. Next slide, please. So DSM-V has advanced our definitions of pain, and it abandons the differential between medically explained and medically unexplained syndromes. It says it's not appropriate to give an individual a mental disorder diagnosis solely because a medical cause cannot be demonstrated. So you can't simply say someone has a somatic symptom disorder because you haven't found an adequate organic explanation. Somatic symptom disorder requires a very positive psychological formulation and understanding of where the pain is coming from. And it's defined by excessive thoughts or excessive feelings or excessive behaviours relating to somatic or physical symptoms. Next slide, please. And the new classification removes some of the rather clumsy diagnoses that were put into the area, such as body dysmorphic disorder, which and also hypochondriasis is renamed as illness anxiety disorder. And it moves in the category of psychological factors affecting other medical conditions. Again, a clumsy phrase in which, for example, I referred to migraine exacerbated by stress. and it also moves in factitious disorder. The trouble with the difference between a conscious and an unconscious causation of pain is that that involves a value judgment on the part of a clinician as to whether a patient is frankly deliberately faking it, or whether their pain presentation is entirely unconscious. And those can be very difficult judgments to make. And unsurprisingly, you find that sort of claimants' representatives are tending more towards somatic symptom disorder, and defendants' representatives are tending more towards factitious disorder, which is really making a judgment about the motives and intentions of the claimant. We also remove the dualism in the diagnosis of somatization disorder, what's been called a Cartesian false mind-body dualism. And for those of you who've studied philosophy, you'll know that Descartes made a distinction between the mind and the body, which is now challengeable biologically. So the idea of pain being either organic or emotional has been removed, and that obviously fits with clinical practice. An individual may be seriously disabled after, quite a complicated physical event. Someone may have a myocardial infarction, but then have a level of physical disability afterwards, which simply isn't explained by the ongoing medical pathology. And in the past, somatization disorder really was requiring us to remove a lot of the organic explanations, whereas somatic symptom disorder gives us a greater ability to make that diagnosis despite the ongoing organic explanations. Next slide, please. And just to give some explanation, we have on the one hand what used to be called hypochondriasis, or now known as illness anxiety disorder, versus somatic symptom disorder. And the difference really is that in the latter, in somatic symptom disorder, people are concerned by the symptoms that they're suffering. They're presenting with pain. Whereas in hypochondriasis or illness anxiety disorder, that the patient is worried by the underlying diagnosis. They're not so much bothered by pain as a fear that they might, for example, have undiagnosed cancer. So the distinction between those two categories is based on whether the person is preoccupied more with symptoms, which is what we find in somatic symptom disorder, or whether they're slightly more preoccupied with the underlying disease, which is what we find in illness anxiety disorder. Next slide, please. So I've talked very positively about new ways of categorizing pain in terms of somatic symptom disorder, but it has created problems, and amongst those problems are legal problems. But with a broad brushstroke, somatic symptom disorder is quite an over-inclusive diagnosis. It's much easier to fit people into that diagnosis than it was into somatization disorder or an equivalent. The other problem is an overlap with other diagnostic categories, particularly adjustment disorder. Where does somatic symptom disorder end, and where does adjustment disorder begin? Adjustment disorder, it tends to be a reasonably trivial condition at a level not sufficient to make a diagnosis, for example, of major depression or generalized anxiety disorder, but where there's an abnormal psychological response to a medical condition. So at what point are you going to say, well, that adjustment disorder becomes somatic symptom disorder? And again, the trend at the moment is that the claimants are presenting more with somatic symptom disorder, and defendant evidence tends more towards adjustment disorder. Next slide, please. So in terms of the classification, somatic symptom disorder is a real clinical improvement. It avoids the false mind-body dualism, but it does hold some disappointments. But importantly, it doesn't require that the psychological symptoms are medically unexplained. It's quite possible to have a myocardial infarction, but still have somatic symptom disorder as an explanation of some of your physical symptoms. It places an emphasis on psychological criteria and on a positive psychological formulation. And it also provides a degree of clinical and legal clarity. It really helps us understand what's going on. Next slide, please. Now, what's happened in America is that the growth of somatic symptom disorder has led to a growth of litigation for somatic symptom disorder, to the point that it's now the most litigated disability. You can imagine the complicated cases that we're all involved in. It's quite a neat category to put people in, and therefore it goes to court. But unfortunately, the majority of those claimants are ending up losing. Next slide, please. So the expansion of somatic symptom disorder and the way that that presents legally has required much more detailed descriptions in terms of expert testimony. You need really robust expert witnesses to support the diagnosis. And often cases are failing or succeeding based on the credibility of the plaintiff. There's been an increase in the use of surveillance and the use, for example, of social media profiles, what one would term free surveillance. And the problem with that is that with somatic symptom disorder, our patients can have really bad days, 6 days of the week, and then they may feel sort of slightly better on a Sunday. So they go to Asda on a Sunday morning, and then suddenly there's a photograph of them shopping in Asda with a smile on their face. And that's unfairly used to undermine their testimony. So somatic symptom disorder becomes quite challengeable in a legal setting by using surveillance and by using social media. And that's the backlash against somatic symptom disorder being so intensely litigated now in America. Next slide, please. So a single photograph taken from one good day can be used to suggest a lack of credibility. Increasingly, there are arguments based on what you could call a crumbling skull concept, as opposed to an eggshell skull concept. In other words, by crumbling skull, I mean that the defendant suggests that this is an accident that was waiting to happen. There was a certain inevitability to the presentation of pain, of somatic symptom disorder, based on the background. And here you find the lay witness evidence particularly valuable, having witness evidence from ex-colleagues, from employers, from friends, as to how someone was presenting prior to the injury. Next slide, please. In terms of the mechanisms of pain, therefore, I'm going to skirt over this in the interests of time. Essentially, what I'm saying here is that the sensation of pain is then filtered by memory and emotion. So the way that you're feeling and the way that you've suffered pain previously will affect how your body and mind experiences the pain. So pain is not simply a matter of me standing on your big toe and your brain going, ouch, but is also affected by whether I've stood on your big toe the week before, and by how your mother or father responded to pain when you were a child. In other words, that the neural networks that govern pain will be modulated by areas of the brain involved in memory and in emotion. And I could talk at length about that, but I'm just going to cut it short there. But to bring home this message that pain isn't just a sensation, it's an experience based around memory, and we have a reasonable understanding of the neural pathways that govern that. Next slide, please. So the interesting aspects of this are that the experiences of pain will be altered by factors such as childhood and development, and how you've been brought up, the sort of traumas that you've suffered in the past. They're affected by ethnicity and gender and even your religious beliefs. And those are factors that are also affected by how the healthcare professionals treating you will manage you. So ethnicity and gender affects how doctors prescribe. One study suggests that the black patients are significantly less likely than white patients to be prescribed medication for the same levels of reported pain. They're much more likely to be given lower doses of medication. women are up to 25% less likely than men to be prescribed opiate analgesia for the same level of pain. A fascinating study looked at atheists versus Catholics who were both exposed to the same pain stimulus, and then they were given the picture of the Virgin Mary while the pain was administered. And the Catholics then rated their pain perception as lower than those atheists. They were then both shown secular paintings by Leonardo da Vinci, and then they reported the same levels of pain. So this really just goes back to my previous slide that pain perception is influenced by beliefs and values and past experiences. And pain is a neurologically complex experience controlled by brain regions that are altering all sorts of experiences, such as anticipation. Next slide, please. So, given the expansion of somatic symptom disorder as a diagnosis in the courts in America, and given the fact that essentially it's a subjective experience, and I will refer back to the Virginia Woolf quote about how can you possibly describe pain, there's been a thrust in America to find some objective measure of pain. And I introduce this just because it hasn't really gone anywhere, but it's quite an interesting phenomenon. In 2005, a claimant, Carl Koch, was very badly burnt in an industrial accident, and he took the case to court against Western Emulsions. And in this particular prominent case, and I'd recommend that you read into it in a bit more detail if you're interested, the claimant instructed an expert, Joy Hirsch, who was doing fMRI research, brain imaging research at Columbia University. And she effectively gave a visual representation of allodynia, excessive sensitivity to pain. She demonstrated that with this particular individual, when his affected wrist was touched, particular areas of the brain lit up with fMRI scanning, whereas the unaffected wrist did not light up. So this seemed to be a visual, objective measure and representation of pain. And this was really welcome to the lawyers who were wanting not to have to rely on whether the claimant's expert was more illustrious than the defendant's expert. Here seemed to be an objective snapshot of pain, like a photograph of pain that could be used in court as a means of proof. Next slide, please. But then the defendant created some counter evidence led by Mackey at Stanford University. And what Mackey showed was that the fMRI images would be altered not just by what pain was being experienced, but also by the expectations of pain, the anticipation of pain. They could be altered by the degree in which you were concentrating on that particular part of your body. He then took a series of volunteers and put them in the same scanners, and he would expose them to a hot plate that would cause, a strong, painful stimulus. And he then created for the volunteers automatic feedback of flames that they could be visually seeing whilst their brains were being imaging. And as they therefore touched the hot plate, he showed that those volunteers could train themselves to diminish the brain activity through learning. In other words, you could cheat the scanner. It wasn't as objective or reliable as was being presented. And ultimately, the evidence of the claimant, which had been hotly contested, was admitted by the judge. But the claim was settled prematurely, and the sense was that perhaps that the settlement was in order to avoid setting a precedent. But I think thereafter there's been very much a quest and a desire to find an objective test of pain, which, if you refer back to Virginia Woolf's quote, simply isn't going to be evident. Next slide, please. So when I'm referred patients who are suffering chronic pain, there's a whole host of different psychiatric comorbidities that we might see. There might be schizophrenia, delusional disorder, but most commonly we're seeing depression, addictive behaviour, personality disorder. And in many of those cases, those diagnoses predate the trauma or injury. So patients who have pre-existing personality disorder or pre-existing addictive behaviour are more likely then to suffer a trauma resulting in chronic pain. Next slide, please. And personality disorder becomes possibly overdiagnosed in chronic pain. Personality disorder is about a series of maladaptive personality traits, which effectively will affect someone from cradle to grave. Now, often personality disorder is diagnosed in patients who are very difficult and challenging. And of course, many patients who are suffering chronic pain are difficult and challenging. Typically, young men with depression don't go to their doctors saying, I'm depressed and sad. They'll present as very angry and quite explosive. So it's easy to overdiagnose personality disorder in patients with chronic pain simply because of the behavioural presentations of the pain. So although personality disorder is very, very relevant as a comorbidity in our chronic pain clinics, it can be overdiagnosed, and one has to be a little bit cautious about that. Next slide, please. So when I'm approaching a patient in clinic, the sort of warning signs that I'm getting at an early stage that something might be going on is of pain that's persisting long beyond the expected healing time. A disparity between the organic findings and the level of disability displayed. An excessive use of healthcare services. I've been in court recently where the defendant counsel has actually quantified the number of GP consultations there have been year by year to sort of use that as a threshold marker of excess use of healthcare services, which isn't always fair, but it does give you a crude measure. Obviously, signs and symptoms of a psychiatric disorder, whether someone's suffering depression or anxiety. And then their use of medications, opiates, benzodiazepines, and alcohol. And in the clinical assessment, I'm particularly eager that patients are referred sooner than later. In a clinical setting, it's not uncommon for patients to go through the orthopedic surgeons, the rheumatologists, into pain management services, and then eventually they come out the end of all of that and they're seeing most commonly a psychologist or sometimes a psychiatrist like myself. And in that care pathway, by the time the patients see us, they're feeling very aggrieved, they're feeling abandoned, and they feel like they've been dumped. It's much better instead to have a psychologist, a pain psychologist who's integrated into the pain team, who's involved at an earlier stage, so that the discussion around psychological as well as physical elements of pain is introduced early. Next slide, please. And the sort of areas you're covering then when you're taking a history are, what is the patient complaining of and why are they presenting now? Sometimes patients have had problems for many, many years, and you have to ask yourself, well, what's the reason for their presentation here and now? What does the patient want? Most patients are looking for cure, and yet most healthcare professionals are trying to shift that dialogue away from cure to one of coping and acceptance. What are the patient's beliefs and fears? Some patients believe that if only they could have an amputation, that would relieve their pain, and they don't understand that actually amputation creates a new hell of phantom pain and by no means resolves the underlying pain. What are the organic factors? What's going on physically, and what physical investigations are still being carried out? And what are the psychological stresses going on in the person's life at the time? What are the maintaining factors? What are the factors that might be perpetuating the pain? And are there relevant psychological issues that are contributing, for example, hyperventilation or addictive behaviour or avoidance behaviours? Next slide, please. So it's important to start off by exploring a patient's attitude to the assessment. What do they feel about being in your clinic? What do they feel about discussing a psychological explanation of their pain? It's very common to experience hostility at this point, and it's very relevant to explore that hostility and to discuss it without simply dismissing it. So one process of carrying out an assessment would be to start off perhaps by discussing the practical issues, the physical issues. They're seeing a psychologist or psychiatrist, but you really want to give them scope to talk about their orthopedic treatments or their anticipations of problems with benefits. So listening to them for quite a long time at the beginning is an important method of engaging them. And only then moving on to the psychological exploration. You give them an opportunity to describe their pain, and pain, as I've said, is hard to describe, but patients will often have their own personal ways of characterizing their pain, can be quite florid ways. Sometimes by the time patients are being seen by a psychiatrist or a psychologist, their families and friends or their GPs are quite fed up with them. So they've stopped talking about their pain, and the opportunity to talk about the pain at some length is welcomed by them. And that can be a really good way of engaging in the psychological process. It can also be helpful to discuss their disability, but also to contrast their level of disability with their level of handicap. If you like, disability is the physical, the medical problem, whereas the handicap is the more sociological way in which that problem is manifest. And is there a difference between sort of the level of disability and the level of handicap? I've recently seen, without going into details, a lot of young men who've lost limbs in Afghanistan, and they've gone on to run ultra marathons. And it's so impressive how the gap between the physical disability and the handicap is really small. On the other hand, some people with a relatively small disability may end up being highly handicapped by their pain syndrome. The next area to look at is how the patients have experienced doctors, how they found doctors have responded to them. Some doctors have been quite dismissive or hostile towards them. I then move on to the illness history, both of the patient, but also of their families. You might have, for example, a patient whose father had multiple sclerosis, and their childhood was dominated by almost being a young carer for their parent. And that perhaps has caused them an array of illness behaviours that have understandably been learnt from an early age. You might take a developmental history. Did they reach normal developmental milestones? Is there evidence of autism spectrum disorder, which becomes a difficulty when it comes to pain management? And that, by the way, crops up in one of the later questions that one of the participants has asked. You look at the history of their emotional state as well as their beliefs and attitudes around their current pain. Next slide, please. I apologise for the quality of this slide. You look at patients' pain behaviours. What are they like when they walk into your room? And an aspect of this which I'm finding increasingly useful is then how their pain behaviour makes me feel. Some patients will walk into the room with a quite potentially annoying repertoire of quite flamboyant pain behaviours. Or they might walk into the room with no sign whatsoever. They've got this blunted, cut-off affect, which makes you not realise that they're feeling very depressed and quite suicidal. So it helps you if you introspect how the patient's pain behaviours leaves you feeling. And the importance of that is that it helps you then understand the patient's life outside of the clinic. What's it like to be their mother or their spouse? So the pain behaviours give you a feeling of how the patient is experiencing life outside the consulting room. Next slide, please. At a very formal level, I'm looking to make a psychiatric diagnosis. Have they got a mental illness? Are they suffering depression? Are they suffering somatic symptom disorder? Are they suffering from addictive behaviour? And secondly, access to diagnosis, by which I mean personality disorder. I've cautioned against overdiagnosing that, but obviously if you have a degree of maladaptive personality traits before a physical injury, then the physical injury is going to present a whole new array of challenges in your life. I might then look at the maintaining factors in terms of relationships, marital discord. What's happening at work? Is the person unable to work? Are they in conflict with their employer? Is their employer failing to make necessary adjustments? Are there iatrogenic factors? Are there medical issues that are perpetuating the pain? Does the patient have abnormal illness beliefs? Do they not really understand what their condition is doing to them? An important maintaining factor is simply chronic inactivity. As an aside, I'm involved in research looking at patients who've been on ITU for only around 2 weeks, and simply laying flat for 2 weeks, completely inactive, creates a level of muscle inefficiency that physiologically causes quite intense pain as you're starting to rebuild your muscle efficiency and muscle resilience. So some aspects of muscle pain are the result of deconditioning. And again, we see that time after time in chronic pain cases. And again, we see a primary role for physiotherapy in helping someone overcome that chronic inactivity and its impact on loss of muscle efficiency. And then we also see as a maintaining factor the impact of litigation and how hard it is for patients to make a recovery whilst litigation is going on. Again, sometimes defendants will suggest that this is an aspect of malingering, but that's far from the truth. That the fact is that if you have had a horrendous road traffic accident and you're having to go to an array of surgeons and physicians and physiotherapists and psychologists talking about the accident time after time after time in a legal setting, that every time you're talking about it, it can cause vicarious re-traumatization, so that the psychological provocation flares up again and makes it far harder to, if you like, draw a line in the sand and look to the future with any degree of optimism. Next slide, please. So before you engage a patient in a pain management approach with psychological or psychiatric elements, you want to make sure that all the investigations have been completed, if possible. You don't want something to come out of the woodwork to complicate matters. I well remember a case, it wasn't a chronic pain case, but it was a functional neurological case where after 2 years of exhaustive neurological investigations, the neurologists decided that the explanations of this patient's hemiparesis were entirely psychological, and that the patient was seeing psychology and psychiatry with a lot of resistance on their part. And we were gradually making inroads. And then suddenly the bloody neurologists found an autoimmune antibody, which I'd never heard of, which they were suggesting actually might provide a new organic explanation of the disability. And we were back at square one. We couldn't do any psychological work because the patient now thought, well, yes, this is what was missed. It was this autoantibody. And then 3 months later, the neurologists turned around and said, oh, sorry, we think the autoantibody is irrelevant. And we're back with the patient again, and the patient feeling very hostile and still suspicious that there might be something organic going on. So when you're treating the patient, you really want the investigations to have been completed. You then bend over backwards to prepare the patient for realistic goals. You're shifting the person from coping, from looking for a cure towards coping. Next slide, please. So there might be symptom-orientated treatments, such as use of psychiatric medication or relaxation. That there may be etiologically orientated treatments for unfortunately, in my experience, a minority of patients, they can cope with quite exploratory psychological therapies. There may be function-orientated treatments. Next slide, please. But you're trying to move from a biomedical model of the pain to a psychosocial model. You're trying to move from focusing on symptoms to simply engaging with the distress. You're looking at moving away from investigations to a much broader agenda. You're moving beyond prescribing towards problem solving. Instead of surgical interventions, you're perhaps thinking about family therapy. Next slide, please. And next slide, please. I'm going to skip over just in the interests of time. Thank you. And next slide, please, again. So essentially, you're wanting the patient to, rather than seeking a cure, to reach a position of acceptance. Ideally, the patient would have specific goals in mind of the psychological therapies. You offer the patient an opportunity to ventilate, to have a cathartic release of their emotions, including anger. You might rationalize analgesic medication and its usage. You would give the patient advice on behavioral activation, on relaxation, and on fitness. You encourage families to be supporting health rather than disability. You want the patient perhaps to have reasonable expectations of their doctor so that they're using their doctors in the most appropriate way possible. And by all means, you're wanting to embrace every possible treatment available, which might involve alternative therapies that you yourself might not be familiar with. There are therapies that work that we don't really understand why they are working, but if they do work, then they have great value. There are therapies which don't have an evidence base that's strong simply because it's really hard to research them, but it doesn't mean the therapies don't work. Therapies come in and out of fashion. One example of that, I think, is hypnotherapy, which is extremely valuable in pain management. It's clearly evidence-based and it's got a strong role in pain management. In the 1960s and 1970s, hypnotherapy was a common treatment in psychiatry. My now deceased father, who was a psychiatrist, practiced hypnotherapy regularly. But it's fallen out of fashion in psychiatry for, I think, no other reason than it's very hard to get hypnotherapy into NICE guidelines because it's very hard to do a randomized controlled trial on it. Next slide, please. So I've left 10 minutes for questions. There were already quite an array of submitted questions. And I'm going to start off by answering 2 of those submitted questions, but then I'll open the floor to questions from participants. So one of the particularly interesting questions was around autism and pain, and how clients who are on the autism spectrum may present with pain and how you might approach them. I have a particular research interest in autism spectrum disorder, particularly actually in women with autism. And in autism, you see both expressive and receptive communication difficulties. Essentially, it's very hard for people on the autism spectrum to communicate their emotions. It also means that they don't understand how you are communicating with them. In my research team, I'm thankful to have an expert by experience as a research collaborator, and she helps me understand what I'm getting wrong. And one thing I've got wrong is a simple open question like, how are you feeling today? If you ask someone with autism spectrum disorder, how are you feeling? They might take that as quite a concrete question. Are you touching yourself? Are you feeling yourself? Or on one memorable occasion, I used a metaphor about keeping your eyes peeled. And for someone with autism, that immediately evoked a rather dramatic, terrifying image of peeling your eyeball. So I think when it comes to pain and autism, it's important to be careful how you communicate and how you listen. Your choice of language needs to be quite subtle, and it might involve very clear and basic explanations. The second factor with autism to consider is that if you're seeing someone face to face in your clinic, patients with autism can really recoil from certain smells and certain sounds. And in a clinical setting, that can make the consultation difficult. The smell of aseptic soap or sudden loud banging noises can disrupt the consultation. And then you want to explain very carefully to the person with autism what you're going to do. If you're going to examine them, you want them to understand what you're going to examine and how you're going to go about it. The other final factor about autism and pain is that some people with autism have a hypersensitivity to pain, but some people also have a hyposensitivity. They can appear to be insensitive to pain, even though they are experiencing it quite prominently. So those would be the factors around autism and pain and how to approach that from a psychological perspective. A second interesting question that was pre-submitted to this talk was around the use of EMDR for pain. Now, EMDR is really a treatment of choice for PTSD. It appears in the NICE guidelines for PTSD alongside trauma-focused CBT, and it's a thoroughly effective treatment. But EMDR was being researched for pain conditions back in 2013. So there is an evidence base supporting using EMDR, eye movement approaches in chronic pain. And the way it seems to work is that it reduces not the pain itself, but it reduces the emotional distress associated with the pain. For those amongst the audience who've used EMDR or see it being used in PTSD, you'll know that sometimes it doesn't take away the flashbacks, but it reduces the emotional intrusion of the flashbacks. It makes the flashbacks more bearable. So in a similar way, EMDR for pain doesn't take away the pain, but it can make the pain more bearable. So I think there is a real role for EMDR in pain management, although it isn't in the front line of treatments. And the final thing I would say about EMDR and pain is that clinically I find it a bit like Marmite. People either love it or they loathe it. And if you are going to take that approach, very often the first session will reveal whether it's going to be useful or not. So questions on autism, questions on EMDR pre-submitted. There are other pre-submitted questions I can return to, but I thought I'd maybe go to some of the audience, the live audience, and ask if there are any questions there.
Thank you, John. We have indeed had some questions through. I'll just have a quick look through for the first one. This one is, what expectation is there on medical professionals treating doctors of patients, for example, who are not psychiatrists, to identify where there may be psychological aspects of pain rather than organic cause, and what is the burden for referral?
Well, I think that's where you want ideally a pain management service that includes a psychologist. So the optimum, and I know this is ridiculously ideal, is that those patients get taken to a multidisciplinary team discussion so that you can be talking about the patient early and you can be raising questions about the warning signs that may be psychological rather than physical. And less typically a psychiatrist, more typically a psychologist in a pain management service has a very real role, perhaps less treating individual patients and more guiding the broader pain management team in those issues. Now, I suspect that's not what the questioner is talking about. I suspect the questioner may be an orthopedic surgeon or a GP or whatever who sat in a clinic thinking something odd is going on here, and yet I can't really readily refer this patient to psychology. All I would say is that you should go with your instinct, and one develops instincts and hunches, and if in doubt, it's better to refer early and get it wrong than refer late, by which time the patient will be so aggrieved at the notion of being sent for treatment that actually the agenda will be set already. Thank you.
Great, thank you. Second question we've had through is, my husband has a neurological pain following a subarachnoid brain hemorrhage 9 years ago. He's tried all sorts of medication, antidepressants, TENS machines, injections, but he's still in pain, unable to sleep. I'm frightened for his future. What else can be considered?
I think the first and honest answer is I've got to be careful not going beyond my area of expertise. I believe Irwin Mitchell are planning future webinars involving pain physicians, and I think that's going to be a question more for them than for me. So here I'm talking more from my professional experience than as an expert. But for example, I do have experience of what is now called central post-stroke pain and used to be called thalamic pain. We don't call it thalamic pain as much now because there can be extra-thalamic causes. And it's bloody hard to treat, and it drives people to distraction. It's almost metaphorically like if you can imagine an itch, but it's an itch inside your body, so you can't get to it to scratch it. So treatments are very elusive, and it's an awful, awful thing to suffer, often associated with lacerating, burning, and aching feelings. And in terms of the role of psychology, I think it's a relatively limited role, but a real role in which techniques such as mindfulness and meditation can modestly improve the suffering of pain. Again, the attempt there not to be to get rid of the pain, but to almost detach yourself from the pain. Now, in reality, most people with this sort of pain, you tell them to go away and meditate. They look at you like you're a complete idiot. And I think those approaches really help a significant minority, but the benefits are very small. The benefits are in the order of sort of 5%. And so with this sort of central thalamic pain syndrome, this central post-stroke pain, you're looking at lots of little things helping by 5% rather than one big thing. And the psychiatric aspects of the management are unfortunately fairly limited. But I would suggest that's a good question for future talks from pain physicians.
Okay, yes, certainly one to pick up later on. We do only have time for one more question, I'm afraid, but for those who have submitted questions, if you haven't left your name and your email, if you can provide that, and we will follow that up. So the final question, you've mentioned that ongoing litigation is often a maintaining factor for pain conditions. Do you have any tips from a psychiatric perspective as to how we might reduce or minimise the effect on this for our clients, given that litigation is often a necessarily lengthy process?
Well, firstly, you want to encourage the claimant to put the litigation in a box and try to forget about it. That's easier said than done. But there are some clinical cases where explicitly the claimant's legal team are actually encouraging the claimant to use a relative as the main interface. So it may be that they aren't getting emails or letters direct from their solicitor, that the emails are going through their spouse or through their father or mother. So putting the litigation in a box and trying not to dwell on it. Secondly, helping the patient distinguish the people who are involved in the litigation process from the people who are involved in the healing process. Now, there are some of you who will be involved in both, and there'll be some of you who aren't. But I'm very clear that I'm usually involved from the legal point of view, and sometimes patients get quite confused about whether they've seen an expert who's there to treat them or whether they've seen an expert who's there to represent them legally. So 2 quick tips. put the litigation in a box and use relatives as an interface. Secondly, help the claimant distinguish the people out there who are involved in treatment from the people out there who are involved in litigation. Thank you.
Excellent. So thank you all for joining us today. If you have any further questions, please do get in touch with us. Please, of course, again, leave your name so we can follow up with you at a later date on any questions you may have. I'll direct you to the Irwin Mitchell website. This has details of upcoming and future webinars, so please do take a look around. There's also recordings on there of previous webinars. If you do have a few minutes to provide your feedback, then please do complete the survey that's been left in the Q&A box. We are, of course, as Professor Morgan mentioned, looking to follow this up with a pain perspective webinar, so do keep your eyes peeled for that. Once again, thank you everybody and enjoy the rest of your day.